Good morning, everybody. My name is Jens Chapman. Welcome to the STED Talk on August 19, 2020. Again, it's my distinct pleasure to welcome you online during this ongoing era of COVID. These STED Talks are spine technology, education, and discovery. And today it's a great honor to have as a visiting speaker one of our own, Dr. Rachel Thompson. She's an MD, MPH. And she's the Executive Medical Director of the Acute Care Medical Services Division. And she's going to talk about perioperative care programs, a framework for quality, value, and collaborative care, which in spine is a huge deal. Rachel, are you on already? Can you see us?
Good morning, I am with you. Thank you for having me.
Well, we'll be joined shortly by her. We have selected 4 cases presented by 3 of our outstanding fellows that illustrate the challenges that we face in spine pretty much all the time. And obviously spine is a very high value, high cost specialty with significant challenges that can occur at any moment's notice if you don't have everything keyed in together. So 4 brief cases will show different vignettes of healthcare. One will be a very healthy patient with a sudden significant challenge to her well-being. Well, one will be a very physically challenging individual, and the other one will be a patient who has multiple morbidities. I think we'll have a 4th case also, and again, to start things off, something that can happen to anybody, so as far as we know, a relatively young, healthy individual. Dr. Lincoln Jimenez is going to take the lead-off spot and present us this case. Each case will be about 5 to 7 minutes long with maybe one question to again illustrate the highlights of the challenges of a system. Lincoln, please take the stage.
Good morning, everyone. My name is Lincoln Jimenez. I'll be presenting this interesting case of a young person with no interest in past medical history or risk factors for developing an epidural abscess. So I'm going to start by saying a 50-year-old female who presented initially on July 29, 2020. And the presentation symptoms were pretty much low back pain with intermittent fevers. She initially, during that first presentation, that first encounter, had a white count of 5.6. She was found to have some bacteremia with gram-positive coccyx. At that time, in spite of the fact that she was having low back pain, it was decided to, because she had no neurological deficit, it was decided to treat it conservatively. And an initial MRI, which I will show later on, was completely negative. Her past medical history, as I said before, was non-significant. She had no neurodeficits. But later on, unfortunately, the patient came back on August 1st of same year, and she continued to have persistent fevers. And her back pain, unfortunately, was progressive and increasing in intensity. She had at this time actually numbness, and particularly when she was standing. She did not have, fortunately for her, any neurological deficits. And at this time, the white count was actually 18. As we see, there is a timeline over here. We actually see on 7/29, we see the first CAT scan, which actually does not show major changes. There is good alignment of the lumbar spine, and we do not see any epidural collection for us to be concerned about. On 7/30, we see that there is no major changes either on the lumbar spine on the MRI. But later on, we start seeing on 8/1, which she came for the second time, that we see a little small collection right at this level, which is posterior to the epidural sac, to the thecal sac. And then at that time, we decided to treat her conservatively. However, the pain and the fever persisted, and not only that, but the intensity was very bad, that 4 days after, the epidural axis was actually increasing in size. Not only that, but as we see here, the first MRI of the thoracic spine on 8/1 was completely negative for any type of epidural collection. However, 4 days after, she developed this massive amount of collection or epidural abscess, for which we decided to do something. So I do have some questions, or we do have some questions regarding this. The first question was, was the MRI too early at the beginning? Should we have waited? Should we have been a little bit more aggressive in the treatment? The second one is, should we have planned for a second without having to have the patient visited a second or third time the ER or the hospital for a second MRI within a week? And if so, if we have decided to do something surgical, what will be the surgical approach? I don't know if you want to continue, Dr. Chapman.
Lee, do we have Dr. Thompson yet? So stay with me here, Lincoln. So this is a great case that shows something that we're really faced with more and more. That's, again, epidural abscesses and de novo infections of the spine. One of our former fellows, Dr. Bletcher, published a very nice paper in Spine that showed how in our state, the number of infections since 2011 has skyrocketed. But it's mainly patients at risk, intravenous drug users, patients with severely decrepit immune systems. As you look at this as future chief of spine at the University of Puerto Rico in San Juan, what are you going to tell your hospital, not just your spine doctors, your ER doctors? What are the main risk factors to look for an epidural abscess?
Yeah. Among risk factors, of course, we have to base ourselves on the age of, and also other risk factors that are not associated to medical conditions. I'm sorry, I'll take this. But if, let's say if it is a young person, of course, I am looking for immunodeficiencies, or second thing is also IV drug abuse. If we get into more of an elderly population and or patients with medical conditions such as diabetes, that will be also my other reason to consider. People that has, let's say, skin conditions should also be on the look for potential epidural abscesses.
And Lincoln, the natural course history of a cervical epidural abscess or a thoracic epidural abscess that is not treated with surgery is usually what? I mean, what's the surgical indication? What's the surgical timeline? Can you wait until a patient deteriorates, or do you want to intervene rapidly?
No, in reality, once you have an epidural abscess, you should be more into the aggressive position. And the reason, particularly when it is in the cervical spine, because these patients actually can deteriorate pretty fast, and you have to act adequately in these patients.
So I think we have received word that Dr. Thompson is online. Rachel, can you hear us? I can't hear you over our intercom yet, so I'm asking Lee to open up the channel. So hold your words for a second. The question I'm going to have for you is, we've here in this patient done 3 MRI scans of her head, neck, thoracic and lumbar spine within about, I think, 4 or 5 days, right, Lincoln? So we did multiple MRI scans, which are expensive, over a short period of time. And despite starting with proper antibiotics, with culture-sensitive antibiotics, this patient deteriorated so that she had to go to the OR, fortunately, before any neurologic deficit occurred. Testament to the great team at one of our hospitals that kind of kept monitoring it, and our ability to get, basically, A, get neuroimaging on serial basis, and B, go to an operating room. Patient was happily discharged. But here we've spent a lot of healthcare dollars on very expensive neuroimaging in a very short period of time. How do we express something like that in a value equation? The ultimate goal, the patient left the hospital, neuro intact, and problem solved. But this is a big deal for us, isn't it?
Absolutely. You get a little echo back. In terms of the value of it, you know, when I think of value, I think of populations, and luckily that dilutes any single effort that we might need to make. It is most difficult in the settings where we have the least understanding of what to do. And with MRIs that lag from what, you know, any radiologic piece is one piece of the larger puzzle. But with the lagging, the question would be, you know, is there even a science to help direct us as to what the timing of repeat imaging might need to be? And really, you get into these cases where there's not a lot of, hindsight can give us all sorts of wonderful things, but as you're going forward, thinking about one day to the next, do we actually want can we project and understand exactly what pattern we're going to need to follow? I'm not as familiar with the literature of MRI spines, but I wouldn't hesitate too much to guess that there's probably not a great evidence base to the frequency for repeat imaging in this situation. So absolutely, having someone on antibiotics early on, and it's the appropriate antibiotics, and it's just progressing no matter what, because it's that insulated space. It's not unheard of, but absolutely a good point. Not sure I could have seen a different way, even in the hindsight.
So thank you for your comment. I'm going to formally introduce you during your part. So the first half will be just a couple of cases that illustrate some of our challenges that we see every day. And we thank you so much for being here. So Dr. Jimenez, in closing for this case, what should have happened in a retrospectogram? Again, the final outcome is excellent. We caught it, we treated it, very rapid surgery that you and I performed late at night, saved the day. Great hospital collaboration between infectious diseases and hospital medicine and surgery. But what could have been done differently from your end now that you look at it with several weeks hindsight?
I think it's important to recognize that we probably missed a little bit the point for which the actual patient came to the hospital, which was back pain, and we focused initially on the bacteremia. I think we could have been more aggressive in repeating that MRI rather than the 4 or 5 days that we did it, maybe a second day when the patient was actually deteriorating already and having a numbness. So that's my take on this.
Great. So infections remain a great challenge even in normal, lower citizens. Thank you, Lincoln. Next, it's my pleasure to introduce Dr. Elias, and he's from Beirut, Lebanon, and our thoughts are with our fellow human beings in the human disaster zone of Beirut. He has 2 quick cases to show that offer different challenges, so we'll ask for your opinions on those, Rachel.
So good morning. My name is Elias. I will be presenting today 2 cases. The first one is about a 42-year male. He has a BMI of more than 65. He has previously done a gastric bypass. He had an IVC filter placement, underwent a C3 to T1 fusion back in 2014. And after this operation, he had a DVT on which he was placed on chronic Coumadin. He had multiple medical history, such as bipolar, depression, osteoarthritis. So this patient started having low back pain back in 2018, associated with left-sided radiculopathy. Over 2018-2019, he had multiple epidural injection. However, his pain was persistent. Here you can see he had 2-level stenosis over L3, 4, 4, 5. Mainly, the most common one was over the 4, 5 with central stenosis. So decision was taken to operate on him, and he had 2 levels laminectomies in 2020. So he was discharged home. 2 weeks after being discharged home, he fell down from his own height. And he started reporting to have a serosanguinous fluid leaking from his wound. So he presented back to the ER with fever and bilateral lower extremity pain. Unfortunately, his situation escalated quickly, and he went into sepsis. A decision was taken to bring him to the OR to evacuate his pus and do evacuation and drainage. However, once in the OR, we noticed that he had bilateral pars fracture over the L3 and L4 area. So patient was kept intubated due to his sepsis condition, and he went for a second wound debridement and evacuation, and he was transferred to the ICU for medical management. Once he was stable enough, he was taken again for the third time to the OR for a flap advancement for wound closure. So once he was stable and extubated, he started again reporting left-sided leg pain and weakness associated with hip pain. And so we had a repeat MRI for him. And as you can see, you have this big epidural, this big abscess collection extending from the L1 area to the L5 associated with discitis. I don't know if you can see it here, and air pocket levels. So we took him for the last time to the OR. We had evacuation of the collection with L2 to pelvic instrumentation.
So Elias, stay here. So Rachel, this is a case of a patient and all visitors to SSFTV of a morbidly obese patient, formerly 800 pounds, now at around the 600-pound margin, despite gastric bypass and everything, who can't walk anymore. One of our service lines really carefully tried to treat him non-surgically. It just did not work. The service line did a very careful, least invasive surgery possible, and not completely surprisingly, everything escalated out from there. An infection, multiple medical problems, sepsis, multiple debridement surgeries, finally a reconstruction surgery, and I guess the patient's doing well. This is the question, Rachel. So as our society is burdened with more and more morbidly obese patients with significant secondary issues, literally addressing anything in their internal organs as well as their cardiovascular system and the musculoskeletal system, these patients provide a major challenge to all systems, including our nurses and on-floor care providers. Financial performance is a big catchword and value. How do we apply value principles when we are faced with such a literally, figuratively and literally, a ginormous challenge? Thank you for taking this question.
This is also, you're throwing some tough ones out here. This is a very difficult case. Our patient's sheer obesity challenge is its own force to reckon with as we have to go through this procedure. That alone increases the risk of so many things, including that of the surgical site infections, and a lot of other risks that he could have faced as well, including really the lack of mobility, the difficulty, the restrictive force on his lungs. We could see all sorts of potential for badness. He does not have a lot of other comorbidity that goes with obesity, but I wouldn't be surprised if he had some challenges even with his glycemic control, given his size. When we're looking at a procedure like this prior to surgery and thinking about what is the best way forward for our patients, it is a very big challenge, and there is not going to be the risks are going to be greater, and there's not going to be a simple process for people to go through with this amount of challenge and comorbidity initially. I think that when we think about how to best get someone through a procedure with this, part of what goes through our minds needs to be, are there alternatives to that procedure? And I think in this case, this was something that everybody has to weigh, which is what are the risks and benefits potentially of going through, and the decision ultimately to undertake this in a collaborative decision-making framework is one that's unique to every situation. How then do we provide the value? Again, you're pointing out a very difficult perspective, because it's not like we can really change this obesity picture in a rapid fashion, similar to what we might be able to do if someone came in with us with a glycemia prior to surgery or hypertension prior to surgery. So definitely something to face. And I fear a little bit that we will see a lot of folks shying away from caring for these more complex patients because of going to more of a value-based payment systems. So that's something that's going to continue to challenge us. Short story, finding everything we can to optimize when we do decide to go through, making sure we're thinking about alternative approaches because we know that complications will be occurring in a patient like this.
Great answer, and thank you for that. And again, this patient, before the first surgery was done, was actually seen collaboratively with our medicine doctors, and so this was not a rush into surgery in the first procedure, but everything escalated. So we've had two problem zones in the two cases so far. One was the morbidly obese more recently, and prior to that, we had the infections that are rising in the state dramatically. A third is what to do with patients who have increasing dementia or loss of mental faculties and spinal cord injuries. Combined in one here, Dr. Elias will do a repeat performance for this one.
So my second case for today is about 74 female. She suddenly had a cardiac arrest after ground level fall. And then she had a return of circulation after 2 minutes. Upon waking up, she had lack of motor movement that was initially interpreted as post-arrest encephalopathy. However, she had intact brainstem reflexes, and which included the cough and gag reflex. Associated with her presentation was severe bradycardia, which required initially a temporary pacemaker placement. Then this was followed by a permanent pacer implant. So part of her prognostic studies, she underwent a CTA, which showed this dense fracture. It showed this type 2 dense fracture on her CTA imaging. So she was transferred to our hospital. She was initially admitted to another emergency department. She had an ASIA 0B score, and she got an emergent MRI. So her MRI showed this contused spinal cord, which clearly showed a spinal cord injury at the level of, we can say, brainstem going down to the C7 area. So despite her poor prognosis, the case was discussed with her husband, and he ultimately consented for an occipital to T2 fusion with posterior decompression from C2 to C7. So as you can see, she had the occipital thoracic fusion with posterior cervical decompression. However, despite taking her to the OR, having decompression, the patient demonstrated a worsening mental status. She was strictly put on ventilator, and she was dependent on the ventilator without ability to initiate any spontaneous breathing. So this slide shows the post-op day 5 or post-op injury day, post-injury day 5 and post-injury day 10. And as you can see, the cord is still edematous with high signal in the cord, which is associated with a spinal cord injury. Unfortunately, patient failed to improve, and patient goals of care changed to palliation, and she expired after extubation.
So this is a sobering case, thank you, Elias, of an elderly patient. The take-home message here in terms of the clinical problem setting is silent spinal cord injuries, especially in patients who are elderly. So myelopathy is a silent, kind of a chronic form of a subacute spinal cord injury. This patient actually sustained an acute spinal cord injury due to an unidentified odontoid fracture. And again, great care was directed at cardiac presumptive disease. Acute pacemaker placement, for instance, reflects another challenge of how to acutely neuroimage patients with pacemakers. This is the point and the question to you, Rachel. So in the value systems that I've seen, myelopathy and dementia are particular challenges in terms of the neuro organs not being, to my assessment, adequately not just reflected in the value equations in terms of the severity of impact of care needs, but also in terms of teaching for medical students. Both of us were involved at UW, for instance, in educating a generation of medical students, and I've always struggled to try to get neuro exams to be a part of a core curriculum. So your thoughts on dementia and myelopathy and things like that challenging us in terms of trying to provide a comprehensive value-based care package?
Right. Thank you. I think this is another it's a sad case, and it's also not uncommon to see. So from the standpoint of the delirium and likely underlying dementia that this patient may have had, absolutely something that should be involved in our initial intake is an assessment of that. I'll talk a little bit more about that as we go through some of the details. We in terms of the just overall neuro exam, couldn't agree more. This is unfortunately, it's the physical exam itself is a art and a bit of science that we have behind it that is not as pronounced in our education as it used to be. And yet really reiterating that so much of what we do needs to hang on a solid history and physical in order to move forward. So I couldn't agree more. And I think I'll address some of this a little bit more as we move into our talk here.
Can't wait to hear you talk. If we may indulge you, one more brief presentation. So we've had 3 crises so far, the CNS degeneration, morbid obesity, and the final thing is, again, now opiate crisis. Our administrative chief fellow, Dr. Puriya Gayumi from USC, is going to present a case with an opiate challenge.
All right. Good morning, everyone. My name is Puriya Gayumi. I'm one of the fellows at the Swedish Neuroscience Institute. This case, our patient is a 67-year-old female with history of diabetes, peripheral neuropathy, chronic pain that was hospitalized on the 1st of June of this year at an outside hospital initially for acute mental status change, severe low back pain, bilateral thigh pain, and an acute inability to ambulate. Her mental status change was found to be secondary to polypharmacy and was treated adequately. A little background, she at baseline ambulates using a walker. She's an active smoker. Takes about 300 milligram of MS Cotton daily for pain control and a few other medications. Her diabetes is moderately controlled, and she denies any trauma, falls, or injuries. On imaging that was obtained at that point, you can see on her x-ray, she has evidence of degenerative scoliosis with lateral listhesis, mostly at L2, L3. She has evidence of severe stenosis at multiple levels, worse at L2, 3, and L3, 4, and to a lesser degree at L4, 5. She was evaluated by spine surgery at the other hospital, and she was found to be a poor candidate for surgery given her smoking and high dose of narcotic use. She was basically recommended that she should pursue pain management and was discharged without any follow-up at that point. She returned to the ED on the 28th of July with elevated white count, acute renal failure, lactic acidosis, hypotension, and continued inability to ambulate, and a grade 4 sacral decube at that point. And our team was consulted, and she was transferred to our facility. On the imaging that was obtained at that point, you can see on the CT scan that was obtained in July, there's evidence of gas in the L2, L3 disc, clearly showing evidence of instability. The x-rays are pretty much unchanged from prior. Her exam, she has evidence of weakness bilaterally, no reflexes, right side being a little bit worse than left. At that point, there was some concern for possible and infectious process by the primary team, so she had an L2, L3 CT-guided aspiration that never grew anything. We did a trial of mobilization and bracing, but given her body habitus and her sacral decube, she wasn't able to tolerate it. Lengthy discussion with her regarding operative treatment, given that it would be a big surgery and her comorbidities. There was a multidisciplinary approach to optimize her medically and nutritionally. When she arrived, her albumin was 2.3, and we were able to actually optimize her pretty impressively. And for the interest of time, I'm just going to show what we did. She ended up going to big surgery, T8 to pelvis with inner body cage at the L2, L3. So in summary, she's doing well, she's recovering well, she's still in the hospital and is walking with therapy now. But this is an interesting case and an important case because aside from the technical and surgical standpoint, it shows a very high-risk deconditioned, a malnourished patient with a very complex condition. And this is the type of patient that is easy to kind of dismiss her problem, but she clearly had an actual problem. She had an acute change in her mobility status. She had acute pain. And also the importance of a multidisciplinary approach to a problem like this. There were multiple teams involved. There was infectious disease, our team, plastic surgery, her primary internal medicine team, nutrition, therapy, and I forgot to mention that during the surgery, plastics also dated the debridement of her sacral DQ.
Thank you, Poria, for this presentation. Rachel, again, this is a theme that you're well familiar with from your days at Harborview and also from Nebraska. There was actually something that Poria did not mention. This patient saw a spine surgeon in the community who basically saw this patient and said, you're too high a risk. She was maxed out on opiates already. She was not walking properly anymore. So there's nothing to do, go home. What sounds harsh is an understandable self-defense also, because of course this patient will have a major problem. Her resultant kind of a deal was she basically laid in bed until she got massive, substantial class 4 sacral decubiti, aggravating any further care needs dramatically. We should add palliative care was involved right from the beginning as an extra service line. We have an extremely strong palliative care service, and they were fantastic in terms of really trying through the encephalopathy that this patient presented with to get through to her. So complex decision-making, polymorbid patient, an early decision opportunity was probably missed out of an understandable self-defense mechanism, but there's no constructive kind of a change towards trying to find a better solution. So, Poria, thank you, because we're a little bit running out of time, but I think hopefully a good starting spot. One of those 4 cases, all of those kind of are challenges to the value equation in terms of for acute care and tertiary coordinary care centers like ours to try to provide good care. I hope these are great kickoff point for you to illustrate what you're going to talk about. It's a great privilege to introduce Dr. Rachel Thompson. To read that properly, she's our Executive Medical Director of Acute Care Services. She's the founder of the Internal Medicine Consult Service at Harborview, which was visionary because nobody had this really, I think 15, 20 years ago. And so we all saw her as an amazing colleague who's working side by side with us and developed this multidisciplinary team concept before it became a fashionable word. Without much further ado, Dr. Thompson, thanks for being here this morning and addressing from a high-level administrative perspective these challenges to fiscally prudent modern healthcare. Thank you.
Excellent. Thank you. Thank you again for having me. And great cases, definitely illustrative of what we face in our everyday experience. Now, one of the nice things, and I think the last case really hits on, is a core concept that we'll just touch on in the next 20 minutes, is around that idea of a true multidisciplinary approach. And what a wonderful job on that last case to have all of those resources. And to your point, Dr. Chapman, really the idea that we are able to do that, we're privileged to be able to do that in our health system. And the idea that we need to help our patients navigate these health systems so that they are able to find a place that can take such a great approach to that. All right, so today we'll go through a brief history and some of the drivers behind the development and the evolution of perioperative care programs. We're going to look at some of the current concepts in perioperative medicine, and then we're going to look at some of the key components of developing collaborative programs. Across the world, there are estimated about 300 million surgeries every year. And in the United States alone, our latest data, which is actually now a decade old, we're due for new, was 52 million inpatient, but 48 million outpatient procedures. And we know we're seeing a shift in that. But the interesting thing was that the average American was anticipated to undergo 9 procedures in their lifetime. One other thing in the United States that we face is our aging nation. We saw that just in the age alone of the patients presented this morning. And this graph here actually demonstrates a projected percentage of the population where in the year 2034, we will have a greater percentage of adults over the age of 65 than we will have of children under the age of 18 for the first time in history. Another part of our population that we're seeing, and I think this is globally as well, is that we're seeing increases in numbers of chronic disease in America. Here we see now today, 6 in 10 adults will have at least one chronic disease, and 4 of those will have at least 2. Just 15 years ago, these numbers were half as common in our communities. One of the things we see, and we just heard about a little bit, was all the complications. 50 million of these occur across the globe every year, estimated. And roughly half of these are thought to be preventable. Looking through what's the most common, at least within our own settings, one of the most frequent is the respiratory set of complications. Maybe not the top of mind when we think of complications, but it is definitely most frequent. Wound complications came in second, with urinary in third. As terms of the most costly, respiratory again is on top of the most costly. Infections, and this is cost per case, infections coming in closely second, and then renal damage being in there as well. In terms of what we can do and what have we seen grow in our response and recognition to the complexities of surgeries, if we look at all publications in the chart here on the left, it's fascinating to look at publications around enhanced recovery, perioperative care, programs in perioperative care, preoperative optimization, and just the sheer number of publications that have occurred in the last decade and really the last 2 decades. But you see a jump in here 2011 to 2020. Again, amongst the spine surgery here on the chart on the right, this really demonstrates that something has shifted in our mentality and how we're not only practicing, but what we're trying and investigating in the world today is really develops around how do we prepare and get patients through surgery in the most efficient fashions. The first sort of landmark article about this really came out of efforts through the WHO. And when we look at their surgical checklist that they published on in 2009, this was a simple surgical checklist that was really designated at the time of surgery. And they implemented this in 8 cities in 8 countries around the world. And we saw that both morbidity and mortality from a pre-post standpoint decreased significantly. When they looked at the items on the checklist to see which ones were most correlated with improvement, it wasn't any single item. It wasn't even a set of items. And so the idea became, is this part of a general safety culture and a sense of taking the time to pause in order to create a system that is improved for patient care through the perioperative time? In the last decade, we've really seen a number of enhanced recovery programs, publications on these, and they all have elements for preoperative, intraoperative, and postoperative. Some of these elements that are important to highlight preoperatively, education, patient engagement in that, and then some of the very specific things that you'll see that are very common in enhanced recovery programs. Rather than belabor these particular points, I'm going to pop right into a recent publication that looked at 19 studies across enhanced recovery in spine surgery. Again, we see the preoperative, intraoperative, and postoperative phases with components that were common to all of these 19 studies. We see the importance of patient education and counseling, that risk assessment, screening, and intervention, and then some very specific pieces. And our final of the 4 patients we heard about earlier this morning really would require a lot of help and coordinated care around the pain regimen that she had been on, and how on earth are we going to manage that going through the procedure ahead. The intraoperative components are also not surprising and are things that we would all be working on very closely between our surgical colleagues and our anesthesia colleagues. And then postoperatively, really at the top there, because it's common to all enhanced recovery programs, is the early mobilization. And this can be challenging depending on what procedure has been done, and it's definitely not in our historical mindset to get patients up and moving, and yet oh so important. The nutrition, so that we're not starving our patients for days, making sure we're not flooding our patients with too much fluid, again, controlling pain the best ways possible and with as little opiate as we can. And then the postoperative monitoring and close follow-up. The overarching principles that they recognize really are the multidisciplinary communication, the feedback processes and measuring progress, using evidence-based as often as we can in all elements, and then reintroduction to the preoperative function, that early mobilization and mobility. When we look at this, so my background is general internal medicine trained, landed in perioperative care early in my career, and then worked with our Society of Hospital Medicine to really develop this framework to help our communities that are filled with our surgeons, our anesthesiologists, and our internal medicine docs really think about how do we get patients through procedures, and really dividing it up into those areas of the preoperative time frame, the day of surgery, the postoperative inpatient for our inpatient surgeries. And I'd add one more piece to dissect that postoperative, to include that post-discharge. And as we face that transition, and there's one of our failed transitions in the cases that I'd say was our patient who did not get a transition at the time of leaving the emergency room, and then went home to their own care to decompensate. So I think transitions are very important for us to be paying attention to, and it's something we can project and we can do a little bit of preventive thinking around as well. I'll give you a couple examples. This is a project that we assembled when I was at Harborview here in Seattle with the University of Washington. When we talk about getting people together and multidisciplinary, we're talking big for some of these projects. And this was the Enhanced Perioperative Care Program that a colleague and I from anesthesia and I worked on for our spine teams, as well as some of our other teams at Harborview Medical Center. When we look at just the sheer number of specialties that were represented in our work group, it is expansive. Pulling all those folks together, we looked at a variety of opportunities, and really identifying these opportunities came from that brain trust of having so many people from so many perspectives sharing in the same room. At that time, we didn't have to have masks, but it was really that important dialogue that started to develop our opportunities. The areas of opportunity clearly in patient experience and engagement, information acquisition and transmission of information from provider to provider, developing true systems and protocols, resource utilization, paying attention to that throughout, and then actually measuring our outcomes and visiting those. I'm going to give you one example of something that happened, and I apologize, this was going to be a animated slide, but we're going to go with it as it all popped up at once. So we identified up there in the upper left corner that preoperative evaluation was taking several appointments, including surgery, anesthesia, and medicine, and patients were on site for about 6 to 8 hours. We had the bright idea that if we designed sort of a back-to-back consult process for our higher risk patients, that this could be more patient-friendly and also could help us get patients through quicker. So what we designed and we implemented with the help of our process improvement team was being able to room our patients. We opted to have medicine do their thorough evaluation initially, then our anesthesia colleagues came in, and then the surgical RN came in, and then we closed with the surgical MD coming in. We dropped our time for our patients, our average time from that 6 to 8 hours on site down to 2 hours and 50 minutes, so just under 3 hours. That we felt very proud of from a standpoint of the patient's experience, but we also learned very quickly that by co-locating, the communication between all of our providers was much more seamless, and it allowed us to make coordinated plans earlier on in the process. So as that program also had multiple other elements to it, in addition to the co-location for the highest risk patients, we actually were able to see reductions in ICU length of stay early on and eventually in total length of stay, as well as some reductions in cost per case. This method of really bringing together a broad group of folks with different visions, different eyes on the same problem, evaluating, identifying, collaboratively designing, going on to implementation, and ensuring that we're measuring and doing things over and over in a continuous process improvement cycle is very important to anything we do in a value-based world. I'll give you a quick look at my time out in Nebraska. We looked at about 15,000 cases that occurred over 6 months. We had about 5,000 of those that were inpatient. 1 in 5 of these were inpatient orthopedic or neurosurgical procedures, and 34% of those procedures occurred in patients over the age of 65. Most, on average, our patients had 2.5 comorbidities per patient, so a little bit higher than maybe the national average, but there we were in Nebraska. The most common comorbidities were hypertension, diabetes, COPD, and depression. We had a tight hospital medicine partnership with orthopedics and neurosurgery, performing preoperative evaluations as well as the postoperative inpatient consultation and coordination. When we looked at this patient subset, our patients that had hospital medicine co-management, and we have 2 pieces here, orthopedics and neurosurgery reported separately, with the number of cases, the case mix index, which is a proxy for how sick of a population we have, and then the mortality index, which is an observed to expected ratio for mortality, and then the readmission rates, the outcomes that we were watching. So in our orthopedic cohort, we saw that we co-managed a majority of the patients. The case mix index was slightly higher for patients with that were being seen by the medicine specialists. And our mortality indexes, I would say, are approximately the same. Readmission rate, however, was lower amongst our hospital medicine managed patients. When we looked at the neurosurgical patient populations, here it was a smaller proportion of the population that we were co-managing. Our case mix index was higher, so definitely the sicker patients were the ones being managed in the multidisciplinary fashion. The mortality index was impressively lower, though as we learned, our readmission rate was quite high amongst that group. Again, something that allowed us to enter into the continuous process improvement, focusing on knowing that we have high-risk patients and that they are likely to come back. So these are just a couple examples from my couple of decades of experience in our realm. I'd say the key components of collaborative care programs really are coordinating the care in all of these perioperative phases, educating and engaging our patients, as well as building systems to ensure the best practices, thinking about early and appropriate triage of our complex medical patients when they come in and they're complex, get that multidisciplinary team going quickly. The prevention and the early identification of complications. We have methods in which we can project and forecast to help us understand what a patient is at risk for, as well as ways to mitigate that risk to the best ability of our abilities. And then always keeping an eye on the continuous process improvement that we can be involved in. I'm going to pause here to see if we have questions, thoughts on that part. And if we still have time, I can take you through a little sample of a preoperative evaluation.
So I really love the data points also. The collaborative spirit was clearly articulated, but having numbers in it is great. We had a question in the chat room by Dr. Rodriguez. He identified a very important question. I think you showed a slide from Harvey that showed about 30 stakeholders. So how do you do a cost analysis so that the hospital system can actually get payment for this? And how do you pay the various physician partners and the stakeholder arrangements that surgeons and medicine doctors and anesthesiologists all kind of get recognition for their participation in this partnership?
Right. And that'll vary depending on the structure and the infrastructure of the health system that you're working in. Something like at Harborview, where the physicians are all employed, it's really everyone's rowing that same financial boat. And so we decide as a system, is this worthy of investment? In a value-based payment model, we would see that that would be part of the assessment, is as we put all of this effort in, how much is it costing us, and do we get that out in the value-based reimbursement that we get setup that we have. That analysis will depend on how you structure it. If it's the physician group that is getting the reimbursement and the value, then we would say, okay, that would be, is this a high enough return on our investment to include that? We have a variety. When you think about that broad piece, you have to think about how do you, that's part of the development phase. The cost of the development was actually minimal because everyone was engaged in that process from a sense of improvement and the need to improve, as opposed to our, having to actually pay people to do a design and to do all of that. So that was part of the generosity and the spirit of the team. When we think about the time for the consults and the time for the actual anesthesia ahead of time prior to the procedures, if we're in a fee-for-service standpoint, it's a little bit less, but we know we're going to sink some money in there, but getting that out on the other end by reducing lengths of stay, reducing costs overall, is where we see that benefit. So it comes out fairly balanced, but it is worthy of watching to make sure that what we're putting in is coming out, and we're not just, so you get a little bit more specific about watching the parts of your program.
So let me give you a practical question, then a big picture question. The practical question is, you showed the ERA slide, the ERAS, the Enhanced Recovery After Anesthesia Services, with Aman Dal from Harborview, a great anesthesiologist. One of the key points there where we face a collision of clinical reality and the abstract desirable spheres, for instance, the cost of anesthetics. There are certain local long-acting anesthetics. There are intravenous anesthetics that are very desirable from their theoretical basis. In practical reality, hospitals frequently don't like to pay for them because they're way more expensive than traditional other things. And so how do you kind of navigate that? Because again, that's something that we practically struggle with very much.
Right. Absolutely. And it's not, like you said, it's not just the anesthetics themselves. I would say, not being an anesthesiologist, but knowing the idea of having to make financial arguments, we really have to be able, this is one of the most difficult areas, but we have to be able to demonstrate that the value is there in some other location. So if we use this anesthetic, what are we going to improve? With the financial data that we were able to track at Harborview, we were able to show that cost per case reduction, which then opens the minds of people. But definitely we're still in a bridging time frame where a lot of people are thinking about this cost is here and it's going to be exorbitant, and it's not, I can't see that it's worth it in that time frame. So we have to open our lens to a broader time frame and say, okay, but the cost is reduced overall. Right now in the fee-for-service model, some of that's around a DRG. If you're getting a payment for a DRG based on your surgical procedure that occurs, and you can shrink how much time and how much resource we use in the hospital, does that time equate to enough money to be able to get us something that will help us help our patients a little bit better? That's one way to do it. When we think about programmatic, American College of Surgeries, actually, surgeons have a lot of data on the ACS website around implementation of programs and how much money that will save you. So, going on even just going online and going into the ACS, you can see some of the financial arguments that other programs have made in order to support the development of your own program.
So thanks for that answer. And again, pointing out the value of research as a teaser. One of our wonderful immediate past fellows, Dr. Ryan Goodmanson, has a great paper coming out on urinary retention. I saw that avoidance of Foley was one of your issues. And again, we actually looked at risk scores for urinary retention afterwards, and as a multi-specialty collaborative effort. And I think there'll be some interesting discussions emerging out of the insights, which do identify that Foleys do have a role in patients. And again, that's something where research hopefully will guide us towards having a more differentiated or predictive outlook. Now, my big picture question to you is, where do you see payment models going? You mentioned that fee-for-service actually has some advantages because you actually get paid for what you do. This is very much counter to what larger government agencies like to do. They'd like to have just one kind of a bucket for some capitated reimbursement. Where do you see incident-based, kind of general disease category-based payment models going? For instance, for de novo spine infections, vertebral osteomyelitis, or oncologic disease. How are we moving ahead in this country as far as you can predict?
Right. Oh, great question. And I feel like we are on this slow transitional train that is moving. We see a lot from CMMS, a lot of programs that are really focused on episodes of care. Many of these are actually currently in their infancy, and they're testing them, and some of them are not working quite well. However, it's still something that's being pushed. I do see that continuing, and there's a lot of thought right now that even with what's happened in the last 6 months around our pandemic and our coronavirus care that we've been inundated with, that cost of care in the healthcare systems really is shifting towards that capitated model or towards an alternative payment value-based model. We have MSSP here, and that's something that is even bigger, where you're paid on a life to care for, so that you get so many lives in your whole group. That's a pure capitation type piece. Those programs are more and more common. We have seen episode of care where you have a 90-day episode where you get a lump sum payment. The way they actually put that into play is that you actually bill fee for service throughout the episode, but if you go over the amount at the end, you're going to owe money, and if you're under, then you may get some money back from the feds. So it's that we're still learning as a country how to manage these payment systems, but they're becoming more and more prominent, and the commercial payers are enjoying that as well. And so we are seeing that trend continue. It's sort of I would say, I would expect it, I would prepare for it, I would think about how do we really drive value, because that is the future. We're thinking about populations, and it's a whole new way for us to be doing medicine in the United States.
So really thank you for taking the time to talk to us and our viewership. I hope the 4 case vignettes showed the real life challenges, which by the way, all occurred within the last month, to the individual patients, their families and loved ones, as well as to the healthcare system and the treating physicians on the ground. We as physicians on the ground are very fortunate to have an administrator like you working, because you've been actually in the trenches and have seen all these dilemmata from your first-hand encounter. So thank you so much for your insights and sharing your wisdoms with you, and an ongoing dialogue in terms of how we can provide high-value care under highly challenging times. Thank you.
Well, thank you for having me. Take care.
Thanks for watching. Hit the subscribe button for more medical content.